Thank you, Professor Nomura, Professor Choi, and thanks also to the organizing committee for the kind invitation to come and speak. So for the next about 12 to 15 minutes, I will be discussing preoperative assessment of resectability in patients with Hilar Cholangiocarcinoma. I was reminded just now by Dr. Rosen that for him, all patients with this disease are resectable because he does liver transplant, but we're not going to talk too much about that this morning. So in facing a patient with this disease, I think there are two questions that we must ask, and we generally do ask ourselves. First, is it resectable? And the answer to this question is largely derived from technical considerations. And I think it's fair to say that the criteria that define resectability are largely defined, although perhaps the interpretation may vary from surgeon to surgeon. But even still, they can be difficult to assess before surgery, and that's clearly demonstrated by irresectability rates that range as high as 50% in some series. The next question I think that we should always ask is, should it be resected? And this, of course, is a much more difficult question to answer. It gets into the biology of the cancer, and the criteria here are largely unknown and largely ignored, at least for now. But I think in the future we will have a much better understanding of the fundamental biology of this cancer that will help us make better decisions. So what constitutes irresectability? Well, this is certainly a moving target. Based on a number of factors. There are certainly surgeon variability, the willingness of a surgeon to perform extended resections with major vascular reconstructions. There's also the ability for us to modify the future liver remnant, which has also changed the landscape of managing this disease. That includes preoperative PVE and also ALPS procedure potentially, as well as the role of transplantation, which I'm not going to spend time discussing. Clearly, in assessing a patient for operative intervention, one must carefully assess their fitness for major surgery. These are big operations that represent a major insult to the patient potentially, and therefore they need to be relatively healthy. Otherwise, certainly assessing their cardiopulmonary status is clearly important, as well as underlying hepatic parenchymal disease. These are not new. The radiographic studies that we use to assess the disease extent and whether the tumor is potentially resectable must assess multiple factors: presence of metastatic disease, whether that be nodal or distant disease, biliary extent of tumor, vascular involvement, lobar atrophy. These are all critical determinants of resectability and have been clearly defined. Well, which studies should we get? If you read reports in the literature, there's quite a bit of variability in terms of what studies people order. CT angiography, cholangiography, MRCP, direct cholangiography, duplex ultrasound. These are all studies that are used by us and by others in combination. Other things to consider: staging laparoscopy. Is there a role? I believe that there is a role in selected patients. PET scanning. Do we do it routinely? Do we do it ever? How much does it add? This is a question that's not very clearly defined. And also, increasingly, we are looking at the quality of the future liver remnant, not just the quality of the size of it. Clearly, that's important, but also the quality and how well it's functioning. We don't have great measures of that at the moment, but whether or not the biliary tree and the future liver remnant is obstructed, and whether we need to perform preoperative decompression. So this is just a summary of the things that we need to look at: extent of the biliary involvement, invasion of adjacent structures, the liver, the adjacent vasculature, lobar atrophy, which is an important determinant not only for resectability but also for preoperative biliary drainage, and whether or not we need to do a portal vein embolization at all. The presence of atrophy can help guide us there. Morphologic considerations: the presence of a papillary tumor, papillary morphology. These tumors tend to have a better prognosis, and a more aggressive resectional intervention is usually warranted in these cases. Well, in thinking about preoperative intervention, which studies are the best? I think some of the best data on this recently published from our colleagues in Amsterdam, Dr. Van Gulik and Dr. Guma's group, In this report, they systematically reviewed the literature looking at imaging modalities, CT, MR, ultrasound, and PET. And they wanted to assess the ability of each of these modalities individually to identify variables or to assess variables accurately that are associated with resectability. They looked for studies that had surgical and or pathological confirmation, needed to have at least 10 patients included, and that the data reported in those studies allowed for calculation of accuracy, sensitivity, specificity. It's quite telling that they looked at almost 800 papers and ultimately came up with 16 that had adequate data, or a total of 448 patients. And here's the data summarized very succinctly. Most of the data relates to CT. In fact, most of the data available was related to CT. There was very little on many of these variables with respect to MR, ultrasound, and PET. And as you can see, accuracy, sensitivity, specificity for each of these variables on the left was reasonably good, although certainly not perfect. And ultimately what they concluded was that the quality data derived from diagnostic accuracy studies are sparse. And most data pertain to CT. That's the most common modality that we use. And there is acceptable accuracy for most of the parameters that we're interested in, but it's clearly far from perfect. And it's also limited in these studies by differences in technique. Not all studies use the same technique of CT scanning. And therefore, comparative studies among these modalities was not really possible. In another study that I thought was also very interesting, they similarly looked at the various parameters that we use to assess resectability and looked at the prognostic impact of these imaging parameters on resectability. So 154 patients at their own center with potentially resectable tumors, 64 of them ultimately resected. And they looked at the predictive value of each of these imaging parameters on predicting resectability individually. And as you can see, these included portal vein, hepatic artery involvement, suspicious lymph nodes in the hepatoduodenal ligament, bilateral biliary involvement, lobar atrophy. And they looked at whether the ability of each of these to predict irresectability, what the yield of laparoscopy would be, and the likelihood of finding metastatic disease. And as you can see from the results, that irresectability was, in fact, predicted by vascular involvement, portal vein and arterial involvement, the suspicion of lymph nodes involved, as well as the extent of biliary involvement. And it seemed that the extent of biliary involvement was perhaps a bit more powerful in this regard because it also predicted yield of laparoscopy as well as the presence of metastatic disease. Now, so it's clear that preoperative assessment based on one or two factors is not perfect by a long shot. And people have over the years tried to come up with preoperative staging systems and whether or not these are potentially helpful. And the goal here, of course, is to risk stratify based on preoperative imaging data in order to assess the likelihood of resectability, whether it's or irresectability based on locally advanced disease or metastatic disease, and also perhaps long-term outcome. The rationale, of course, is it would be great to be able to reliably identify high-risk patients so that those patients might be perhaps subjected to more intensive preoperative staging, like PET or laparoscopy, in order to clearly identify metastatic disease and take them out of the pool of patients for resection, or to treat them up front with neoadjuvant therapy and potentially improve outcomes. There are a number of systems that have been published, and we'll just go over them quickly and assess their utility. The bismuth correlate system, of course, everyone knows it's the oldest staging system available. It classifies tumors based solely on extent of biliary involvement. It's the most commonly used, but it does not account for many other critical variables. It only accounts for extent of the tumor within the biliary tree. So in that sense, it is limited. The AJCC system, everyone is familiar with this. This is the most recent edition, the 7th edition. This is a pathologic staging system, and while it does allow us to stratify patients in terms of outcome, it is based on assessment of resected surgical specimens and therefore has very limited utility preoperatively. This staging system, reported by a multinational group of authors not long ago in hepatology, was proposed in order to fill the gap in this area. And it's a very comprehensive staging system based on 9 clinical variables related to not only the tumor, but the patient as well as the liver remnant. It's a very comprehensive system, although it's quite complex in nature, and its utility remains to be seen and confirmed. The Bloomgard staging system, which was proposed by my mentor Leslie Bloomgard some years ago, I think has some potential utility. This system is fairly simple in nature. It's a staging system based on three important variables that dictate resectability: extent of biliary involvement, portal vein involvement, lobar atrophy. And then patients are categorized using data from preoperative imaging into one of these 3 groups. And here's the staging system summarized quite succinctly. T1 tumors are the least advanced. These are tumors that involve one side or the other of the biliary tree and the biliary confluence, but don't generally have vascular involvement and no atrophy. The T2 tumors, more advanced, ipsilateral vascular involvement or ipsilateral lobar atrophy. And the T3 tumors, more advanced yet again, bilobar biliary involvement, or tumor on one or the other side with contralateral vascular involvement or atrophy, or both of those features. And in our experience, we find this stratifies patients reasonably well. If you look at the preoperative staging going from 1, 2 to 3, we found that resectability rates correlate very significantly in an inverse way, and the likelihood of finding metastatic disease also correlates. These findings were corroborated independently in a study reported from China, where again, staging 1, 2, and 3, resectability rates inversely correlating with this, the likelihood of finding metastatic disease, as well as the survival also correlating, which we hadn't previously shown. More recently, in a study from the Mayo Clinic, 80 resected hilar cholangiocarcinomas were evaluated retrospectively. These patients all had bismuth correlate 3 type 3 tumors, so they were all tumors that extended well up into the liver. These patients underwent hepatectomy and bile duct resection, almost all of them with R0 resections. The authors conducted a survival analysis and compared AJCC staging with Bloomgard staging system. And what they found was that between these 2 systems, only the Bloomgard system really correlated with survival. Both systems actually were reasonably good at predicting resectability, but Bloomgard stage did correlate with survival. One last point to talk about, because it is important in this disease, is preoperative assessment of the future liver remnant. We're all well aware that many of these patients do require biliary decompression, as well as preoperative portal vein embolization in order to make the operation safer. Preoperative outcome is critically dependent on the future liver remnant in terms of both volume and function, and biliary drainage and preoperative PVE are both used to improve the integrity of the future liver remnant. And these results from Japan reported some years ago a testament to this, with resectability rates that are superb, morbidity rates that are about what we would expect, but mortality rates low. One thing I think it's important to point out, though, is that even though biliary drainage is commonly used, we have to be careful how we apply it. And I think not every patient does require it. This is data from Memorial, where we looked at 60 patients with hilar cholangiocarcinoma. This was retrospective data, retrospective analysis. And we stratified patients based on their preoperative future liver remnant volume and whether or not they had the future liver remnant decompressed prior to operation. And what the data showed was if the future liver remnant volume was already adequate, as you can see on the right side of the flow chart, so over 30%, the morbidity and mortality after resection was quite a bit lower than it was if your future liver remnant was smaller. And in fact, in the patients with greater future liver remnant volume, likely the result of atrophy of the side to be removed, that it almost didn't matter if the future liver remnant were decompressed at all. And in fact, the only mortality that was seen in this group occurred in patients who had stents. And so likely we're exposing these patients to the risk of sepsis related to placing stents and not offering a benefit to decompressing a future liver remnant that's small in size. On the other hand, in patients with small future liver remnant volumes, the failure to decompress was a bad decision and often resulted in postoperative mortality. This was a paper recently published, a multi-center study in Europe that essentially arrived at the same conclusion. 366 patients evaluated preoperative drainage in 180, operative mortality 11% overall, higher for right hepatectomies than for left, not surprising. What the authors found was that preoperative portal biliary decompression did decrease mortality after right hepatectomy, and that's not surprising because of the much greater volume resected with a right hepatectomy. On the other hand, a left hepatectomy, preoperative drainage increased operative mortality due to an increased rate of sepsis. There was a lower likelihood of dying from postoperative liver failure given the smaller volume of the left liver. Finally, just a quick word about ALPS. This is a technique that's emerging and is getting a lot of attention. This is a technique that involves in situ splitting of the liver with portal vein ligation to allow for rapid hypertrophy of the future liver remnant and then a completion hepatectomy sometime 7 to 10 or 14 days later. This technique is illustrated here in terms of how it's conducted. The first operation splits the liver, divides the portal vein to the side to be resected, and then a second operation after adequate hypertrophy of the future liver remnant is done to complete the resection. This is a technique that's being employed increasingly in a number of settings. Whether it's applicable to Hilar Cholangiocarcinoma remains to be seen. This is a recent study from Germany that highlights some of the problems potentially with this technique, in particular related to Hilar Cholangiocarcinoma and the potential for sepsis-related morbidity. And in this study of 9 patients, 2 died postoperatively. Both had Hilar Cholangiocarcinoma. And I think we need to be a little bit careful about this procedure, particularly in this population. So I will stop here and summarize by saying that preoperative assessment of Hilar Cholangiocarcinoma remains a challenge. Multiple complementary studies are generally used and are required. The best combination is ill-defined, and there may not be a best combination, but I think a good combination of high-quality imaging is definitely the best approach. And irresectability rates, despite advances in imaging, do remain higher than for other diseases that we deal with. Predictors of irresectability in advanced disease include biliary tumor extent, vascular involvement, and suspected nodal involvement, and we need to be aware of that. Preoperative staging systems may be helpful because they consider multiple important variables that dictate resectability, correlate with resectability rates in advanced disease, and they may be useful for identifying high-risk patients, not only for targeting them for perhaps neoadjuvant therapy, but perhaps also additional staging. Thank you very much for your attention.